Good morning. My name is Julie Hibben. I work for the Iowa Department of Public Health, and I want to welcome you to our second webinar in our training series on the Strategic Prevention Framework. We are glad that you can be with us today. Just a couple of quick reminders before I turn it over to our presenters. One is we are recording these webinars, and we will be posting them on the IPN webpage. I'm hoping the ones that we have recorded thus far will be posted on Monday, so be watching for those. In addition, any resources that are shared and the PowerPoint presentation itself will also be posted on the IPN webpage. So if you would, just make sure that you're muting your lines when you're logging in. So we just cut down on background noise. We'd appreciate that. And then I will go ahead and turn it over to our presenters this morning, Lori Barger-Sutter and Mary Ellen Shannon with Growth Partners.
Good morning, everybody, and welcome back. I just noticed one thing in the chat, Julie. It looks like there might be one person that's having a hard time hearing the webinar. So if you've got any kind of troubleshooting you can do with Jerry,
yes,
that might be helpful. But welcome back, folks, and we're so glad that you've joined this webinar series. And again, the series is really designed for all prevention practitioners, whether you're brand new or have decades of experience. The series is designed to help you maximize your use of the Strategic Prevention Framework and avoid common pitfalls. Today's webinar will build on the information that we shared earlier this week, and it'll include a specific focus on planning, implementation, and evaluation. And once again, as Julie mentioned, we've got your lines muted just to make sure that we have a quality recording and also to help us get through all of the material. But we may have you open your lines at the end, and certainly want you to know that your questions and comments are very, very important to us. So we want to make sure that as they come up for you, as you're listening to the training, please do include your questions and comments using the chat feature on the Zoom platform. So if you're not familiar with Zoom, I think most of you are, but if you're not, you just kind of find your little bar at the bottom, click on the chat icon, and a window will pop up for you to use as your chat. Any questions that we cannot get to today, we will carry over into Monday's interactive question and answer webinar that's scheduled for 1:30 in the afternoon. And then just a final reminder, the Iowa Department of Public Health is still finalizing the processes they will use and require of their contractors. Therefore, the terminology, processes, and documents that we use in this webinar are for demonstration purposes and may or may not reflect the final specific processes adopted by IDPH. But with that said, the content and concepts that we're presenting today are applicable to all kinds of problem-solving frameworks, including but not limited to the SPIF. So without any further delay, I'm going to turn this training over to your presenter, Lori Barger-Sutter.
Good morning, everyone. I want to thank again those of you who joined our call on Tuesday and shared some of the situations that you're sort of working through. It was really, really helpful in terms of helping us take kind of theoretical concepts and really think about, applying them to your specific circumstances. So as a result of that call, I wanted to spend just a few minutes this morning kind of recapping some themes that we talked about. And the first one starts with the issue of language and a comment that I think I opened with on Monday, which was that SAMHSA didn't invent the concept of performance management when it adopted the SPIF. It really kind of put its own name on it. And we got into a conversation on Tuesday about another very common framework that is used in the field of public health, which is the mobilizing for planning and partnerships. That's very common in public health departments that the CDC has funded. And so I created a couple of slides just to do a comparison of that. So, I mean, these are the 9 critical elements of MAP. I think as you read through them, they probably sound very familiar to what we talked about on Monday. If you're new to the SPEF, or if you've that this probably looks very familiar to you. And one of the things I wanted to just address this morning, and Julie, I ask you to help me out with this. One of the elements of the MAP is building on previous experience. So it's kind of meeting people where they are, not expecting them to stop everything they've done before or redo everything they've done before and do it over again. And the issue came up, I think, on the call on Tuesday about somebody who was working with a drug-free communities grantee who had already done their assessment, and they were kind of feeling kind of uncertain about how do I ask them to, work with me and completely redo what they've already done when they've done their assessment, they've been funded, and they're working on implementation. And so I wanted to just spend a minute this morning, Julie, kind of clarifying that. So is it acceptable for for the IDPH's contractors to kind of meet people where they are, kind of adopt maybe what assessment they've done to date, and then just, build on it or supplement it or find ways that they can bring value to a process that may already be existing?
Lori, are you wanting me to comment on that? Sorry.
Yes, yeah, just to clear that up. Is there an expectation that everybody stops everything they're doing and starts from scratch?
No, not necessarily. We will have specific deliverables that they will need to complete for the Integrated Provider Network grant. Now, we know, just like we've talked about in the last couple webinars, that everybody has kind of differing levels of capacity within their communities that they're serving. And there may be some great data you've already collected, or you may have, like Lori was mentioning, a drug-free communities grantee in your community that you're partnering with, or that is a part of your organization. And you can pull data from that project as well. So it's not that you have to start from scratch. You need to be really considering what else is going on in the community. If there's someone else that's already done some really good review of assessment data, you can pull from that. You don't have to reinvent the wheel necessarily. But yes, we will have a deliverable you'll need to complete, but you can certainly build upon the work that's already been done in the community.
Perfect. Okay, that's exactly what I thought. I just wanted to confirm that. So, so if you've got existing efforts in your community, then that's terrific. And as Julie said, you can pull from those and find ways to build upon or strengthen them or bring value to the efforts that are already going on. So I did another slide, just a crosswalk. So SAMHSA has the Strategic Prevention Framework. The CDC, or Centers for Disease Control, has long had the 10 essential public health services, which look very similar to the SPEF, as we'll see in a moment. And then the CDC funded, through the National Association of City and County Health Officials, or NACCHO, this planning process, which looks very much like the SPIF. And I thought it might be worthwhile to spend a few minutes just crosswalking those this morning, because if you're working in public health departments, I thought it might be useful to know kind of the framework and the language that they speak and how that intersects with the SPIF. So to help you kind of speak their language, you will still be calling it the SPIF yourself, but I think, as you'll see, it's very, very familiar. So Phase 1, so I've got the map process in the yellow boxes. Phase 1 looks a lot like what I think of as initiation and talked about on Monday. And it's kind of beginning to plan, beginning to get kind of a core group around you. It should be in the SPIF, but it's kind of built into the capacity or the mobilization step. Phase 2 of the map is doing visioning. Sometimes this happens in the SPIF, in the strategic. It doesn't specifically call it out, but as I talked about on Monday, I think it's a really important step, and I talked about it in terms of mobilization, in terms of kind of galvanizing people to action, to solve problems by giving them a really really good picture of what the future would look like if that problem didn't exist. And then phase 3 of the MAP process is conducting an assessment. So they have some kind of common sense precursors before they start assessing. So these blue boxes then are the first 2 essential public health functions. Which you can see they both have to do. The first one has to do with, I think, a little bit of evaluation too, because you're monitoring health status, but then diagnosing and investigating health hazards, clearly a part of an assessment function. And then steps 3 and 4, or not steps, but essential public health services are informing, educating people, mobilizing partnerships. So very clearly aligning with the SPIF and supporting that organizing for action. An 8th public health service is workforce development. So another direct alignment with the SPIF's capacity building. In phase 4 of the MAP process, you begin identifying strategic issues, and that's where we'll actually start our process today with strategic planning. Phase 5 of the MAP, you're formulating goals and objectives. Here we see the public health, essential public health service, another one, which is developing policies and plans to promote health. And then the final phase of the MAP process is just combines implementation and evaluation. And we see another 3 essential public health services, all of which have to do with implementation and evaluation in terms of enforcing laws and policies, linking people to services, evaluating the effectiveness. And then finally, there's a final public health service. I'm not sure that it really aligns with the SPIF. I don't think it's prohibited, but in terms of conducting research. So I want to pause for a moment and see if there's any comments or questions about, it's a kind of a complicated slide, so I broke it down so we could kind of walk through it a little bit slowly, but I want to see if there's any comments or questions about how similar the process that public health community uses to the SPIF. And Mary Ellen, I will rely on you as always to call out anything that pops up in the chat box.
Absolutely. Yep. No comments or questions coming in. And again, as a reminder, you just kind of need to click on your chat icon at the bar at the bottom of your Zoom window if you want to use your chat feature. Okay, no comments.
Okay, great. So I think this gives you a way to talk to people who may say, well, we already have our planning process, to talk to them about how really essentially you're doing the same thing, and the processes you're engaging in are really very similar in that, you know, there's strength in numbers and it makes sense to work together. So I pulled a couple other things from on the left you have what is called a jelly bean diagram. Comes from the MAP User's Handbook, and it just shows how you know, the connectivity between all these different groups, that all of whom may be performing public health services, even though they don't think of themselves as public health entities. And on the right, we have our concept of prevention systems that we discussed on Monday, which is a little bit more, I think, intentional coordination, as opposed to just, you know, all being connected in some way. Kind of shows how you can take that diagram of different entities and kind of shape what they do a little bit so that they're all working toward specific common outcomes. Okay. So when I started, well, go back. So on Monday, we also touched on the concept of a syndemic, or a synergistic system of linked epidemics, and that the only way to really, that this is what actually most of the problems that we work on look like. They are intertwined with a whole lot of other issues, and the only way to effectively address a syndemic is to bring people together in the kinds of partnerships that we had on the previous slide. When I was working in public health, in my first major project that I was directing in the early 90s, it involved working in schools. My funders were the CDC and the Public Education Network. At least that was its name at the time. It was the professional association group of all of the public school foundations. And we were charged with addressing youth behaviors and promoting academic achievement by addressing youth risk behaviors. And there was a lot of resistance. The schools really felt like they needed to really just focus on academics. And so there was resistance to bringing additional programming into the schools that was working on things like substance abuse. So I found this cartoon and adopted it. Those were the labels that I put on the bags that for a particular school I was working with that had very high rates of kids who lived in transient situations, who were homeless, high population of refugees and immigrants. Lincoln, Nebraska, where I live, is typically one of the top cities for immigrant refugee relocation per capita in the country. And so we also had a lot of children who had lived through genocide in their countries. So I probably could have layered on a lot of different bags, mental illness, you name it. But my point was to the school administrators and the school staff that kids don't leave their bags at the door, that these issues do impact academic achievement. And so by addressing youth risk behaviors, we've got to think of them holistically and put together partnerships, school and community partnerships that could work together to address all of the different factors that were keeping kids from achieving. So I wanted to pause again for a moment and just do a little poll here. So thinking about this, and it doesn't have to be children, it could be adults entering a workplace, or could be any kind of situation. But what are some of the labels that you would put on the baggage that the people that you work with have to carry? I want to get a sense of some of the issues that you all are dealing with.
Poverty is one.
Yeah, that's a big one.
lack of transportation,
Yep.
incarceration,
Yep. Yep.
families that are separated,
Yep.
and the lack of structure, homicide, and suicide.
Yep.
Addiction,
Yep.
disabilities,
Yep.
and I suspect problem gambling is another one.
Yeah, a whole host of addictions. Okay. So that all sounds really, really familiar. When I said on Monday that everything important that I've learned in my professional life came from working in or with communities, this was probably one of the most important experiences that I had working in. We had a dozen schools working with families and children who were dealing with the issues that I've put here, and then again all of the issues that you've brought up: poverty and transportation issues and suicide and homicides, and it's the most extraordinarily complex work that can be done, is what you all do every day. And so just walking back, it makes a lot of sense. If you're really going to make progress in these issues, you've got to have partners. You can't do it sitting in an office. That you've got to go out and build those partnerships. And I think this is where prevention is really extraordinarily well positioned to do this work of building partnerships and breaking down silos and of circumventing language issues and being able to explain to people how you really are all working toward the same thing, and to achieve it that you have to work together. So one of the things we touched on Monday too, and this is my last recap slide, is that concept of different kinds of partners. And so I did a little crosswalk. So I talked about stakeholders, and that being kind of the biggest group. They're the people who have some kind of interest or vested interest in what you're doing because they'll be impacted by it. And on the MAP process, they call this the circle of information and awareness, that you got to be aware of you got to know who your stakeholders are, and you've got to keep them informed and aware and supportive of what you're doing. But they're not necessarily going to be interested in doing everything with you all the time. They're going to be okay with just being kept informed. And the second group is collaborators, which are those that are going to actually work with you. And the MAP process breaks those into two groups. It talks about assembling a core group around you, which may be as small as 2 to 3 people, but you can totally count on them, and they're going to be shoulder to shoulder with you, working every step of the way. And then a slightly broader circle of engagement, which could be people who are on a board, of an effort, or could be in the example that we talked about Tuesday, a group of people who convene monthly, who represent different human service agencies, who convene to share information. And so that might in some ways be a circle of engagement, depending on how active they are. But you can count on those people to do things when you need them to, but they're not necessarily going to be shoulder to shoulder with you every step of the way. And then I talked about allies and opinion leaders being people who will champion you. And I distinguished between those as opinion leaders being people who may be prominent, that when they voice an opinion, people listen and they're persuasive in getting people to change their minds or to adopt something. Opinion leaders are really important if you're dealing with entrenched paradigms and you're needing to get people to kind of open up their minds and see things differently, or agree to a course of action that would change things. And allies, in this setting, they're going to champion you too. They don't necessarily have to be opinion leaders. They can be people who work in different ways to help you out. The MAP process calls both of these groups circles of champions. But I think it's a helpful way to think too about when you do your work in the community. You don't have to, and it's typically not a good idea to try to make everybody that has a stake in this sit down with you and go through the assessment and planning process every step of the way, because for most people, being beings that are geared toward action, that can feel excruciating. It's like, just let me know when you're ready to do something and I'll help out. So it's really not only okay, but pretty savvy to figure out, of those collaborators, who has an interest in data, who has an interest in planning, recruit them to work with you, keep your stakeholders informed every step of the way, provide them with opportunities to jump in and assist wherever they have interest, and then know who your allies and the opinion leaders are, who your champions will be. Keep them informed as well so they can kind of keep paving the way for you as you're moving forward. I want to pause here and see if there are comments or experiences people have had kind of working within these different types of partners, or any questions. Mary Ellen, anything?
No comments or questions.
Okay, so we will move on then. Before I do, I'll just say I dwell on this a little bit because I find that it sometimes is relieving or freeing for people, because we sometimes have a mindset that we have to get everybody working with us every step of the way, or people may have a conception that if coalition members or partners or people who come to your meetings and they take on assigned roles and responsibilities, and in fact it doesn't have to be that way, and it usually works better if it's not.
And Lori, we've got a comment here that says that somebody's thinking of some folks' roles and that change over time. Exactly. From levels of lesser to greater involvement, which I think is a great point also.
Yes, absolutely. Absolutely. Thank you. That's a great point, that these roles aren't static, that they do change. And you may have collaborators that move on, and you may have stakeholders that become collaborators, and absolutely. Okay. So I'm going to move in then to our strategic planning part of the day. These are the topics that we're going to be visiting. Again, so to reiterate what Mary Ellen said this morning, we're going to be showing a process that we use and teach. We developed it working in states and communities, so It's where our framework came from, but it doesn't necessarily represent what specifically you'll be required to do as a deliverable for IDPH, but the concepts are pretty, just like the SPIF is very similar to the MAP. What we do is, contains the essence of strategic planning, so it should map pretty well to your deliverables for IDPH. And I want to say too, so throughout this, I've chosen to use an example of some work that we did about a decade ago in Genesee County, Michigan. I've used that as an example to populate the strategic planning process because it's one of my favorite community success stories. And I've lightly fictionalized it as Gordon County in this, but I began working in Genesee County about 10 years ago. In Genesee County, the population center there is Flint, Michigan, which, if you know about Flint, you know that it was very significantly impacted by the downsizing of General Motors. It lost a lot of its population. It lost a lot of its economic base. It went down from, I think, population cut in half to about 80,000 people, and enormous rates of poverty, addiction, every kind of social and public health problem you could think of. They were facing, and so it was an intriguing challenge to go in. They had an early SPIF grant and had never really done strategic planning, had never done assessment, and was a very, very fractured, fragmented community with lots of very different topic-specific coalitions, but not really a history of working together. And I learned so much working in that environment, and they had some really amazing learnings and results. And so you'll see Gordon County showing up, and that's really Genesee County and Flint. So do that little caveat. So this is what we call our planning map, and I'm going to populate it as it goes. But we start, of course, with assessment. And the first two things we're going to talk about is problem statement and target population. This planning map also comes from work in states and communities. I think we developed it, for Illinois communities, probably, Mary Ellen, 12 years ago, when they were first beginning to do the SPIF?
At least. Mm-hmm.
Yeah, and it just was a popular sort of framework, and we've continued to use it and refine it. So this is our planning map, and you'll see it grow as we go. So, through assessment, you're going to be coming up with a strong picture of a priority issue, and we call that problem statement. It's just a very concise description of a priority issue that you've identified during your assessment problem. It describes what is happening, how big is the problem, where is it happening, when does it happen, who is it affecting? It could be all of those different pieces. And if you have more than one priority issue, we really encourage you to keep them separate and to develop a separate problem statement for each. And we may break down the planning process into more pieces and steps than you may be used to. And that's intentional on our part because we're trying to kind of slow people down and help them get a really good understanding of what's going on. So there are 3 qualities of a good problem statement, supported by data, widespread consensus, that people will agree, yeah, this is a problem, and that there is political will in the community to solve the problem. So we think starting where there is consensus and readiness and the problem is well understood is a great way to actually advance community readiness, rather than spending time trying to get people ready to maybe address a behavior. If you can find a consequence of the behavior and you can support it by data, you know that people are in agreement that it's an issue and that they're willing to come together to do something about it. It's a great way to begin, and the successes you get there will generate readiness for addressing the behaviors themselves that drive the problem. So in our example, Genesee County used their local hospital staff to be both their assessors, to guide their assessment process, and to be their evaluators, which I thought was brilliant because it kept money in the community, it engaged the hospital, and it brought in people to help with the assessment and the evaluation who really understood the community and were invested in it. The downside was that the hospital staff were so data focused that the assessment went on and on and on, and they laugh about it. I've stayed in contact with them over the years, and they still laugh about it. That, you know, how they just kind of got into that analysis paralysis because there was so much data, and it became difficult to know where to stop. And so they talked a lot as I went to their meetings and I listened to them. Their primary focus was their youth, and they talked about how serious their dropout rate was. They talked about 17-year-olds showing up with their third pregnancy. They talked about incarceration being a career path for their youth. And so I was pretty certain that when they got done with all of the analysis, they were going to do something focused on youth. And I had been just kind of coaching them from the sidelines about problems and, you know, the same things that I'm sharing with you. I was really surprised when they came back to me and they said, we've settled on the problem that we want to focus on, and it is alcohol-related motor vehicle crashes. And I was, like I said, I was really surprised. I said, okay, well, tell me about that, because I really expected you were going to want to do something about underage drinking or, you know, these things that you've talked about. And they said, well, that is a huge issue, and we're really concerned about it. But our schools, you know, they'll come to our meetings, but they're not partners in collecting data. We don't have good data on, you know, we don't have school survey data. We don't have other data. So it's difficult to measure this problem. There's not widespread consensus. A lot of people in our community say, you know, I drank when I was a kid. Kids will drink. It's the way things are. And so we don't see people embracing this. And we're so fragmented, we need to start with an issue that everybody can agree on. And they said, we have the second highest rate of alcohol-related motor vehicle crashes in the state, behind Detroit. A lot of people die every year, and everybody's in agreement that that's a problem. And there's political will to address this. And so that's where we started. I brought up the LAC track on Monday, I think I did. And it's one of the two most common pitfalls in strategic planning, I think, which is starting out and defining your problem as a lack of something, because it's a common sort of human behavior to say, you know, we have underage drinking because there is a lack of things for kids to do after school. But we all know that the problems are much more complicated than that. You all talked this morning about all of the complicated issues that are driving problems that you are facing. And so when we frame a problem statement as a lack of something, from the outset, it narrows the planning focus. It directs your energy and resources to actions that may or may not be valid or effective on their own. It can cause you to miss other important factors or variables. And it frequently places blame on one sector. When I began in Nebraska working in behavioral health, what I heard from communities were, well, we have one of the highest rates of underage drinking in the country because there's a lack of enforcement. If the police would only do their jobs, we wouldn't have this issue. And it became very clear very quickly when I began asking questions, well, where are kids getting the alcohol? And they said, well, it's easy for them to get. They get it from home, they get it from liquor stores, our non-compliance rate on sales is really high. And I say, well, why doesn't law enforcement enforce the laws? Well, because the sheriff's an elected official. If he didn't pour out the alcohol and take the kids home and he charged them, he wouldn't be reelected. And so very quickly, people gave me lots of context about other things that were happening. And so if we'd only focused on trying, the lack of enforcement, we would have missed some really important things like community norms, retail access, social access, and we would have driven our law enforcement partners away by putting the blame on them. So there was a version of the LAC track that almost derailed the effort in Genesee County, and I'll get to that in a few moments. So here's an example of a problem statement. It gives a lot of the things that I talked about earlier. So when in 2018, 122 people, this is made up, I don't know, it's been a decade, I don't remember how many people were dying in Genesee County, but hence the fictionalized version. But in 2018, 122 people died due to alcohol-related motor vehicle crashes in Gordon County, which has had the second highest rate in the state after Metropolis for the past 5 years. So this problem statement gives you a lot of information. This is for your stakeholders. It's a way to succinctly and quickly convey to the people you're trying to mobilize what the issue is. When did it happen? Who's impacted? It doesn't give you all the information, and you could focus on different pieces, but here's just one example. And so we plug this into this is the strategic planning template we use. I'm going to use it as an example throughout. And again, this won't necessarily look like what you have to do for IDPH, but the concept should be very, very similar. We developed this, to give you some history, we developed this for the state of South Dakota many years ago. They had historically one of the highest rates of underage drinking in the country. They had watched some of the things we've been doing in Nebraska and asked us to come in and work with them, and we helped them completely redo their contracting process and then work with their communities and their providers to do early SPIF. They actually transformed their block grant before they ever had a SPIF grant. And the template we've continued to use over the years, what we like about it and think is helpful is that it incorporates implementation and evaluation into it. So as I walk through, in the white is going to be what we've done. The kind of the yellow highlight is going to be where we are in the planning template, and the grayed out areas where we'll be going. So in this first example, we've got some basic assessment summary. We know The consequence is the second highest rate of fatalities in the state. We know that the rate has been growing every year. And our problem statement then, just encapsulates the consequence. So the next step in our planning map is we're going to be looking at goals and objectives and talking about the second most common pitfall of strategic planning, and that is jumping to strategies before you have gotten really clear on what you want to achieve and what success will look like. And I'll talk about that more in a moment. I probably should pause here and see, are there any questions or comments or experiences that you have to share on developing problem statements of your own? And Mary Ellen, I'm counting on you as always to be the chat room hostess.
I know. Yep, we've got a quiet group out there today.
Okay. That's Friday morning. So, okay. So we will move on. So at this point, this is where we begin to break it down into smaller steps than you may have used in other planning processes. So when we're talking about goals, we are simply really just inverting the problem. So we're focusing on what needs to change. We're not worrying about a specific degree of change or a time frame. We'll look at that later. You'll need to, our advice is create at least one goal for each problem statement. But try not to have more than 3, because usually when you have more than 3 goals for any problem, you're probably trying to do too much and you're diluting your effort. So it's more important to really figure out what needs to change. What's the most important thing to change and start there. You can always add new goals as you complete your initial goals. So not jumping to strategies. This is the most challenging part of the process. And so the advice that we've developed over years of doing this with communities is to kind of watch your language. If you find yourself using an action verb, you're going to provide something, you're going to train people, you're going to enforce something, you are talking about what you plan to do. And that's jumping to strategies before you've really done your full analysis and figured out what's going on and what needs to happen. Once you've said what you're going to do, that's going to be your focus, and you're not going to be looking at additional factors or variables that may be really important, and this could sabotage your efforts and your success. So at this point, you should be using descriptive verbs. You're talking about changes in conditions or changes in problems, not what you're going to do. So if you find yourself or your partners using action verbs at this stage when you're doing goals, objectives, and outcomes, ask yourself, I find the easiest way, and I do it myself. I jump to strategies because that's my human nature. But when I do that, I found that if I ask myself, why do I think I need to do this? It almost always leads me back to what I'm hoping to achieve, not what I think needs to be done. And again, I'll give an example of this. I've got a great example of how jumping to strategies could have really changed outcomes significantly in Genesee County and prevented them from getting the success that they did. So an example of a goal statement is simply reduce fatalities. In this case, reduce fatalities due to alcohol-related motor vehicle crashes. It's as simple as that. People usually want to make it more complicated, and there's no need to. And so here we see we've got our consequence assessment, we've got our problem statement, and now we're just plugging our goal into the planning template. So at this point, the planning group in Genesee County were doing a lot of talking. They had done some, their assessment data had shown them that the fatalities were clustering. They had done some geomapping, some really good assessment of geomapping, or the hospital staff had, and they could see that these deaths were clustering along a 3-mile section of the Dort Highway in Flint. And they knew from their motor vehicle data that it was primarily, the drinking drivers were primarily males, ages 21 to 25. So they had some really great information. They knew this 3-mile section of the highway. They knew some key demographics of the population. And they were really frustrated because in Michigan, at least at that time, sobriety checkpoints were not considered to be legal. They were considered to be unlawful search and seizure. And so they were really frustrated because they said, if we could set up surveillance and do sobriety checkpoints along this section of the highway, we could catch a lot of drinking drivers. And I was listening to them discuss this and get more and more frustrated. And I was reflecting on the fact that their goal was not focused on a behavior. It wasn't focused on reducing drinking and driving. It was focused on reducing fatalities. But they were talking about drinking and driving, and it made a lot of sense. But I also knew that, say, in Nebraska, people, we had a lot of children dying in alcohol-related motor vehicle crashes. And one of the strategies that were being used in some communities were things like helping children, developing skills for not getting into cars with parents or adults who had been drinking. So I knew that there were other possibilities. So as I heard them discussing and kind of lamenting their inability to employ this strategy, I asked them who was dying. And they kind of got quiet and they said, we don't know. There was an assumption that it was these males, 21 to 25, who were drinking and driving, but they had to go back to their data to do some additional assessment. And that's a great illustration of the fact that this SPIF process is not linear. It's iterative, which means you're frequently going to be moving back a step, back and forward, back and forth. So they did some more investigation, and what they found surprised them. Certainly, those males, 21 to 25, were a significant percentage of the fatalities, but what they found was that these accidents were also being caused by pedestrians who were intoxicated, who were maybe crossing the street or walking into the street, as well as bicyclists who were intoxicated, who were crashing into or causing crashes with vehicles that had drivers that weren't drinking. And so a sobriety checkpoint, while it would have caught a significant part of the problem, it definitely wouldn't have caught it all. It probably wouldn't have caught those pedestrians and the bicyclists. And so the problem was more complex than they had originally imagined. And that made all the difference. So when they began looking at their target populations, it expanded quite a bit. So for them, their universal populations, anybody traveling through Genesee County was at risk, because while these issues were clustering, they weren't certainly just restricted. Their selective populations, people that were at increased risk, was anybody traveling that section of the highway where the crashes were clustering. And then their indicated population, who they thought were drinking drivers, was actually drinking pedestrians and drinking bicyclists. And so the question became, what are the factors that tie those three groups together? The drivers, the pedestrians, and the bicyclists. What are the intervening variables that exist that are common to those three groups that they could impact to drive down this rate? So let me pause, see if there's any questions or comments there.
While we wait for folks to submit any comments or questions, we did get some feedback that although there's no questions coming in, at least one participant out there feels like what we are sharing is extremely helpful. So thank you for that feedback.
Yeah, it's very helpful to hear that you think it's helpful, because it's challenging doing this and not being able to read faces and body language. So I appreciate that. All right, so our next step is objectives. And I think yesterday I talked about intervening variables being, I think of them as a sweet spot of problem solving. One of our Mary Ellen and I's colleagues, male colleagues, calls it the meat and potatoes, which always makes me laugh. But this is the point where you really have the ability, when you understand what's driving the issue and you focus your efforts on that, it's where you can make significant change, usually very quickly, and usually for less money and resource than you may have imagined. I talked about that we had developed this planning template for South Dakota a number of years ago, that they were revamping what they did. It was a difficult change initiative for them, and a lot of people had to change the way they were approaching their work. But I have to share, it's one of my, I was so proud of them. They went from one of the highest rates of underage drinking in the country to, they dropped it 50% in 5 years. They ended up below the national median. It was a lot of work. They still talk about how hard it was, but I just share that as you can make significant change by implementing the SPIF or similar processes and really mastering them. So it's hard work. And so I like to share those kinds of examples of successes, because it's what keeps me going. All right, so there's a really important concept involved in intervening variables, and we don't really talk about it much in prevention, but it's commonly discussed in other fields, and it's the Pareto principle, or it's also known as the 80-20 rule. It came from an Italian economist years ago who was an avid gardener, and he he made some discoveries in his garden that he began to apply to his work as an economist, and then it's been adopted throughout many different disciplines. And it basically, the 80-20 rule says that in any group of things that contribute to a common effect, so think of risk and protective factors or intervening variables, that relatively few of those contributors, so generally not always 20%, it could be 30, it could be 15, it could be 25, but in general, 20% of those contributors will account for the majority, or about 80% of the problem. So he began calling these 20% of the contributors the vital few, and the rest of them the trivial many. And the same holds true when you look into research on the strength of correlation of intervening variables in prevention. We see the 80-20 principle, the Pareto principle, show up time and time again in terms of the variables that have the strongest correlation and impact and drive the problem. So some examples of the Pareto principle in healthcare. We know that 20% of patients account for about 80% of healthcare spending. In sales, there's a general principle about 20% of customers will account for 80% of profits. And when you have a computer or technology issue, about 20% of all the potential bugs in the system result in 80% of the crashes. And there's some workforce research that says about, those 20% of overachievers create about 80% of the outcomes. So the implications of the Pareto principle in our work is that if we can find not just all of the intervening variables that are contributing to a problem, but we can identify that 20% that are driving the bulk of the problem, and we focus our efforts there, that we can get significant outcomes quickly. So this is an example of a Pareto principle chart. It just kind of shows, we like to think that life is like that red line, that for every amount of effort we put in, we get a consistent and equal result. But that's not how life works. It's more like that green 80-20. Usually out of 5 things that we do, only one of them is going to have a significant impact. So again, it's being really conscious and intentional about the things that we do and really focusing on the things that are going to have the biggest impact. So here's an example in behavioral health. This comes from the National Survey on Drug Use and Health. It shows where in the year 2016, where people who reported misusing prescription drugs reported obtaining them. So clearly at a national level, if you are wanting to drive down misuse of prescription drugs and access, we all know that access is a huge variable. We would want to focus on friends and relatives and prescription from one doctor. Those would be the sources that we wouldn't, these others are what Pareto would call the trivial few. Okay, so here's our strategic planning template. We have now plugged in the intervening variables, which are really critical, which was that all of these people who were drinking and driving accessed alcohol either through retail or restaurant bar source past the point of intoxication, and that's illegal. And so while they did many different strategies, that's what they chose to focus on. And so here we have our direct target populations. And then we also have what emerged from that was the indirect target populations, retail clerks, beverage servers, and people that are out with those who are consuming alcohol prior to traveling. Again, so the reminder is we don't want to jump to strategies when we are developing our objectives because we're still trying to change conditions. And so in our example here, the primary objectives became reducing retail access and reducing overservice of alcohol restaurants and bars. They did a lot of other things as well. They did some information campaigns, but they kept their primary focus on what they felt was the most powerful intervening variable. And they identified these through some additional data collection that their law enforcement partners did. They had never collected point of source data before, and they started doing that. So when they were investigating alcohol-related motor vehicle crashes, they began collecting data on where people had obtained their last drink of alcohol, and that allowed them to begin to pinpoint specific outlets and specific sources where people were being overserved. So in our strategic planning template now, here's the back half of it. So we're plunking in our objectives here. And now we're going to the last step before we begin to identify strategies, and that is what you may be used to doing in an earlier phase, and that is setting measurable and time-limited outcomes that you want to achieve. We hold off on it because I feel, or my experience has been, it's helpful for people to get really clear about what they feel needs to change before they have to start trying to put measurements to it. And that's the reason that we do that. And we break the outcomes down into three. We long-term outcomes, so that's the measurable degree of change in the problem or the consequence within a specific period of time. It's going to relate directly to your goal. Your intermediate outcome is going to be that change in the intervening variable, and so it's going to relate directly to your objective. And that's why on our planning template, they tend to nest right below. So your long-term outcomes are right below your goals, and your intermediate outcomes are right below your objectives. And then your immediate outcomes, finally. So if you're going to change these intermediate outcomes, you're going to achieve your objectives, what kind of change in knowledge, skills, and abilities do you need to create, and by when? And so again, we're still, for the last time, we're holding back from jumping to strategies. We're just simply trying to quantify those goals and objectives. And so here's an example. We want to reduce the rate of alcohol. So we've taken our goal, and we're just simply putting a measurement to it. Their goal was 10% in 5 years in Genesee County. And their measurement was they were going to use Department of Motor Vehicles crash data. And so your intermediate outcome is going to directly align with your long-term outcome, right? Because that's what's going to get you to the long term. And so here and again, I've made this up, I don't recall what their exact measure was, but reduce retail sales of alcohol to people who are already alcohol impaired by 25% in 4 years. There's different measurements you could use to do this. One could be non-enforcement compliance checks, where you're using coalition members to go in and, maybe act impaired or, exhibit signs of impairment to test whether people are, selling. You use point of source data. I know that was one of their sources. And then reducing alcohol service in bars and restaurants. Again, it could be observational studies. It could be, again, point of source data. These are just examples. So again, then in order to achieve your intermediate outcomes, in order to reduce retail sales, in order to reduce overservice, what kind of knowledge, skills, and abilities do you need to build? And this is an intentional drill down on our part. A lot of times we're kind of rely on strategies. We go to strategies and we take whatever changes in knowledge, skills, and abilities they provide for us. But this is kind of approaching it from a different direction and saying, getting really clear about the knowledge, skills, abilities you need to build, so that when it gets time to pick that strategy, you're picking the strategy that's going to get you exactly what you need. So here we need to increase retail clerk knowledge of laws. We need to increase their knowledge of the signs of alcohol impairment. We may use pre-post test data just we might adapt. We'll see how we do that. We'll come back to how we actually measure that in a few moments. And then increase their ability to refuse sales of alcohol. So, okay, and just walking through this, the server is going to look a lot very similar to retail. And it may be as simple as revising and updating, fine-tuning training that already exists. So here we are in our planning template. We've now put in our long-term outcome. It relates directly to our goal. We have plunked in our intermediate outcome. It relates directly to our objective. And then we've put our immediate outcomes down here along the side. And I'm going to pause for a moment because I see some comments coming in. Are there things that I should know, Mary Ellen?
It sounds like we're really getting folks to think very deeply. So folks are just asking if they can get copies of this presentation so that they can reference back to it. And
Okay.
absolutely, we will make
Okay.
it available to Julie. Yep.
Okay. And I'm going fast. I actually thought we'd get done with this early today. And I see we're, so I'm picking up the pace a little bit and going through a little quickly. So you see it looks very similar here, reducing alcohol service. We're getting really clear on the outcomes that we want. And now we get to the strategies. We get to satisfy our human desire for action. And we know from the research that the most effective plans are not just individual focus, getting individual people to change their behaviors and their attributes, but actually controlling factors in the shared environment. And our planning example is a good example of that. So we may implement programs, we may change policies, we may change practices. So beverage service training is certainly a type of example of a practice that came on here. We know that evidence-based strategies are important, that they need to be based on a strong theory or conceptual framework. And unfortunately, what we've been trained to do as a field is to, and I see this everywhere, is to pick strategies off a list. But that's kind of like going into your neighborhood pharmacy, and somebody says, you know, everything on the shelves has been approved by the FDA, pick whatever you like. And you end up picking products because maybe you saw them marketed, or your neighbor says, I used it and I felt better. And we've been kind of trained to do the same approach in prevention, and it hasn't served us very well. And that's why we've gotten very intentional with this planning process and helping people get really clear on what it is they want to achieve. So your strategies that you pick should be conceptually a good fit. They have to be aligned with the intervening variables that are most contribute to that problem. You know, there are any number of things you can do, but they need to be addressing the things that really drive the problem. They need to be a practical fit. So they need to be carefully aligned to the capacity and the resources and the readiness of your community to implement. And so these are just some different considerations that you want to think about when you're picking strategies. Again, you'll get a copy of the PowerPoint. This is small, I know, and I apologize, but this is an example of a guidance document that we developed when we were starting out, kind of getting communities to not just pick off of a list, but to really strategically think through strategies. And it's daunting because to look through all the research and try to determine is difficult. And so we were trying to break it down for them and kind of walk them through. So, you know, target population, target setting, is it valid or replicated for particular populations? This is communities mobilizing for change on alcohol. And again, this is old, but it, you know, walk through what do you have to do? What are the outcomes you could get? What are the documented outcomes? You know, what are the cost estimates? You know, what do you have to do for training and technical support? What are the materials? And if I had this to do over again, there's something that I would insert that I didn't know at the time that we developed this. And this would be to look very carefully at effect size. So all of these strategies that we have the column for documented outcome area, and we see substance abuse. It's been documented to produce some benefit or some outcome in substance abuse. And the research has been such that the outcome is statistically significant, meaning that it's not just due to random chance. But what we don't know is the effect size. So different strategies have different effects and different strengths of effect. So what we don't know, for example, is did it change substance abuse 1%? You know, and that was statistically significant in that we know that it changed at 1% and that couldn't be by random, or did it change substance abuse by 25% or 30%? Effect size is critical, and it's not something as a field we've been trained to look at or to ask for, and it's a really important consideration. So I'm going to move on. So we're back to our planning template. Now we're at the strategy. We're going to train alcohol retail clerks on sales, laws, signs of impairment. Here we are on our second objective. Again, we're just kind of laying out, here's our broad course of action we're going to take. And now we're moving into the final, which is implementation and evaluation. And this is where it's going to bring us home with our strategic planning process. So the things that we're going to look at here: activities, timelines, processes, roles, responsibilities, and outputs. So as a manager of the initiative, now you and your partners have to break this down, right? If we're going to implement this strategy, what are the specific activities that need to occur? I've just populated it with some examples. I've never actually personally done responsible beverage service training, so those of you that have probably know a lot better than I do what you need to do, but you're gonna lay it out, you're gonna have your timelines, who's responsible. Outputs are things that are, you know, quantifiable and tangible. So might be the list of edits and the revisions that is developed, might be the final curriculum, might be the number of clerks that you train, and could also actually participant feedback would be a better process indicator. So it's a good example of how you can do this process for years and years and years, and then you make little mistakes and you come back and you look at them with new eyes and you say, oh, that goes over there. So this, and what I like about this, what has proven useful about this kind of a format is it gives you a management plan. It's not just your strategic plan. It's not narrative heavy. It's very common sense, and you've got a management plan at the end where you can monitor the implementation. So here's our objective 1.2, looks very similar. And now we're moving into evaluation. Once again, as a field, this is probably, we're fairly good at process evaluation. We're not so good at outcome evaluation, at least not past immediately. And I don't know about Iowa. I'm speaking from experience in other areas. So quantitative and qualitative are the kind of the two dual lenses of evaluation. We tend to be better in as a field as qualitative evaluation versus quantitative, particularly with regard to what degree of change happened. So process evaluation is when you're monitoring all those process indicators that you've outlined in your plan. You're looking at, are the outputs being produced, so that you can make sure that things are being implemented as planned, that you're reaching the people you said you would reach. And so here are some different considerations for process evaluation. And the idea here is that you're monitoring every step of the way, so that if you need to make a correction, if you're not getting the results you want, you've got real-time information and you can make changes as needed. And every step of the way, you're kind of reviewing what's going on and you're saying, what are we learning here? Outcome evaluation is that degree of change. So you will have established a baseline through your assessment. An outcome, you're going to be monitoring progress towards your long-term outcomes, your intermediate, and your immediate. You're going to be looking for patterns in data. You're going to be looking, are there any other explanations that could exist for why we're making progress or why we aren't? And from the very beginning of your initiative, you're going to be looking at what data are we going to collect, from what sources. This is going to have a strong tie-in with your evaluate or your assessment. How are we going to present this information to our stakeholders? By what timelines? How are we going to tie our outcome and the process evaluation together? So here we are now down at the bottom. You see these long-term outcome indicators, and they can be very simple. It's just simply they're looking annually to say, year 1, year 2, year 3, are we making progress toward our outcomes? Here we've got our intermediate outcomes. Again, it's the same thing. It's just setting benchmarks in between the intermediate and the present. And then over here, we've got our process indicators. And yeah, I made the correction there. So our output might be feedback, but the process indicator might be, so what did the feedback say about how well people liked the training and the quality of it? And same thing on objective 2, looks very similar. And there we are. So I want to say, I got to finish my story. So I told you I was using a lightly fictionalized version of Genesee County. Their goal was 10% in 5 years. What they achieved was a 50% reduction in 1 year. And what they found was that when they began targeting outlets that had been illegally, particularly the retail outlets that had been selling alcohol to people who were already intoxicated, they found that they were engaged in all kinds of law breaking, from drug sales to weapon sales to in some cases prostitution. They kind of ran into a web of interrelated problems that were emanating from these outlets that were engaging in not just one, but multiple illegal behaviors. And so when we presented at CADCA on the initiative many years ago, the captain of the Michigan State Fatal Alcohol Crash Team, who was a key partner in this initiative, reported that not only had they reduced alcohol-related motor vehicle crash deaths 50% in 1 year, but they had made a significant dent in violent crime in the city of Flint. And they quantified their cost savings at somewhere around $20 million. I always wanted to see their evaluation data and how they came up with that. I never did, but it was his report that we saved the city and the county about $20 million, and we spent $180,000 on our initiative. That was their budget. So it was a huge outcome, and I've stayed in contact with them. The young prevention coordinator who was new at the time we were doing the effort is now the NPN of Michigan, and I've been working with her in other efforts, and she's let me know that they've maintained that significant drop in the rate over the decades since they began their initiative. So that's my happy coalition success story. So we are at the end. I will turn it over to Mary Ellen to close us out, and Julie, and also see if there are any burning questions for our remaining 7 minutes.
Well, folks, if you've got any remaining questions or comments, please feel free to enter them now. I'll just mention too, to kind of continue what Lori said, you know, we've been in a lot of states. We've seen a lot of communities that work with the SPIF, and we've seen a lot of folks using process, but not seeing results. And so we caution folks that if you don't see results, then something's not going right. Because we know we wouldn't be in this business of doing this training unless we knew firsthand that this works. You know, if you use this process and use it well, and really use data to make your decisions, then you will see results. Any questions or comments? I don't see any coming through. We do have our final coaching call will occur on Monday at 1:30. And again, we appreciate if you guys submit any questions or comments. If you have something that you're struggling with and that you want us to kind of work through it with you, that's what we did on Tuesday's call, is we just kind of took the information that we taught and applied it to a real live scenario. So we would be happy to do that again on Monday's call. And if any folks are willing to kind of bring their scenario to us, we'd love to work through it and problem solve with you. And it doesn't necessarily have to be specific to, you know, this implementation, planning and evaluation process. It can be related to any part of the strategic prevention framework. And Julie also is emphasizing that we will make sure that the PowerPoints and all of our training is available on the IPN webpage, along with the recording links to everybody that will be available. And somebody's asking if Tuesday's taped webinar is also available to listen to, and it sounds like it might be. Julie can confirm that. Wonderful. Folks, we have had a great week with you. We so appreciate your joining this webinar and going along with us and understanding the SPIF. And please do email us, reach out to us at partnerwithus2019@gmail.com if you have anything for Monday's webinar. We look forward to talking with you then. Have a great rest of your day.